So we're trying to work with Valtech, and they're going to give us some great examples of what they did for us in this 2-week period with a sample of the data that we got.
Thanks, Julie. So, what our opinion is, Valtech's opinion on data is the most valuable data is timely. It's layered with external data, combining external data and internal, so it's not the one-dimensional data that Julie was talking about. It's disaggregated. We want to get away from this view that aggregated data is great. Disaggregate it, because only then can you start to make new connections and make new insights out of it. If you're already aggregated, if you're already told this is everything presented to you and you have no way to drill down to lower levels, you automatically cut out a vast number of insights that you could drive from it. And it also needs to be anonymous, because what we're talking about here is, if we're going to that level, we're talking about individuals and individual performance, and what maybe transparency and open data has been miscast as is a kind of a source of fear within the NHS that you're going to hang me out to dry, because you're going to present me to the public where I am in a league table with absolutely no backstory and no right to reply. And automatically that stops people from reporting data in the first place, because why would you? We want to get away from that. So what we're going to talk you through is what we did in just 2 weeks with that opinion, that we want to find the most timely data, we want to find disaggregated data, anonymous data, and layer it with new external sources. There was all sorts of hypotheses we came up with. One of them, for example, was, does A&E admission rates increase with the moon cycle? At full moon, does the A&E suddenly get inundated with people who could be werewolves? We're not really sure. But there were things like that people swore blind was true, anecdotally, and we wanted to actually find out. And you can do that. You can find that data because you have external sources and you have your internal A&E admission data. So what can we do with it? What fun can we have with it in order to find these new insights that can help us make decisions? So I'm not going to talk you through what we did every day of the 2 weeks. We've written about it, it's on our blog, valtech.co.uk, little plug there. Go and see what we did. But I'm going to talk about just 3 of the principles that govern the project and govern what we do and how we work and how government projects now should be working. It's about collaboration. So it's about multidisciplinary teams, so policy units, healthcare professionals. It's about Julie's NHS team. We had one data analyst, one data scientist, a UX person, and a project manager. That was our team. And we all got together. We're all in the same room for most of the project, at the same desk, because high bandwidth communication, working all together. When you have 2 weeks, you can't wait a day to make a decision. You have to make it right now. And when you're working with data sets and things don't necessarily work out perfectly, you need to be able to pivot really quickly. You can't afford to ask for more time. You just don't have it. So we got together on day one, representatives from mental health, from hospital health, from dental care, from cancer care, and we sat down and said, right, what are our hypotheses? What do we think is the easiest way, the quickest way to identify what the user need is? Because what we're doing here is some discovery work. And in a discovery, if we're talking government digital service standard, a discovery exists to validate and identify, is there a user need? Is there any point in us building a digital service for us? And there's something like My NHS that's already live, it may seem mad to even ask that question, but it prompts you to answer some question and really to think very carefully around what the user need is. Because what you don't want to do is get 6 months down the project, burn all the money, all the effort, all the time, and find out that actually you've completely gone in the wrong direction. And users are over here doing their own thing on Google, and you're over here with your service that you've put all of your time and effort into that's not meeting that user need. So it prompts you to force those answers out. So it enables us to make all these job decisions really quickly and ensure that we're meeting our goals. We set the goal at the start, put everyone together, lots of stakeholders all together in one room, always good fun on the first day of a project, loads of energy, obviously lots of concerns as well that come out of it as well, lots of constraints that we had to get out with people and lots of assumptions. The whole point is you get it all out in the open, everybody feels involved, everyone feels part of it, and that's again why we're here today, because we want everyone to feel part of this. It's my NHS, pointless if we developed it outside of the wider community. So collaboration is really important, focus is obviously really important when you have 10 working days, but focus is really important, full stop, when we only have 200 weeks to deliver 5-year forward view. So yes, focus, really important. We wanted to get away from this too many cooks that can sometimes happen when you have mass collaboration with lots of stakeholders. So we had to set the vision really early, establish what could be achieved in 2 weeks, and time box the entire project. Make sure that we could really set ourselves on the right path from day one and structure a plan together based on some hypotheses. That's ultimately how we develop services. We set some hypotheses. We say we believe that if we do this, this can happen. And then you build some tests, you write some tests, and complete some activities in order to validate whether that hypothesis is true. That then helps you to understand what the service might look like in the future. And that was kind of how we structured it. We had 8 hypotheses, some of which we went through and went perfectly to plan, others we had to park. But the whole point is you constantly reprioritise so that you're continuing to deliver all the way through the project. You don't get stuck and go, okay, we can't do anything that isn't working. We have to pause the project. And that's where this comes in, agility. So yes, focus is important, but you have to balance that with the time you've got available. So where you hit barriers, how do you go around them? How do you find new ways to get to the same objective and deliver the same outcome at the end? So we're constantly reprioritising. Again, important to be in the same room with people when you're reprioritising, so you can validate that. Are we still going in the right direction? Are we still delivering what we set out to achieve? And that way we're able to keep going and keep delivering that value back. So yeah, 2 weeks seems like a ridiculously short amount of time, but the results we got out of it were really surprising. So out of discovery, typically you should be delivering these sort of things. So some validated user needs. Yes, there is a user need for my NHS, big surprise, but we were able to validate that to take it forward to the next stage. We delivered some working dashboards. I'll show you a couple of videos in a second, using real data that is currently available, currently public, but we were able to show that by presenting in a different way you can drive some really interesting insights out of it and some real value, we can then start to use to iterate the new NHS service. We've got some documented user research. We actually put this thing in, put prototypes in front of users. With 2 weeks notice, it's amazing how many people they still want to be involved. The fact that you guys are here, you're interested in what my NHS is as a service, you want to be involved in it. We want you to be involved as well. So we were able to get user research. We were able to iterate some prototypes. We've actually got a laptop set up, so if anyone wants to get hands-on with it, come and see us afterwards, play around with the data, see if we can come up with some correlations that we have missed, and some new insights. I'm interested to see what you guys get out. And then we create some insights and some really interesting stories out of it as well to take to the next stage. So I'll talk to you about 2 of the hypotheses rather than go through all 8 because we don't really have time. One hypothesis, we believe that by providing a way to navigate data relationships in a meaningful way, we can help people to compare their organisation to others using better structured and visual data. The summary of that is better comparison means better decisions and better understanding of the bigger picture. So if you can compare, it means you can make better decisions. And the problem with a lot of data at the moment, particularly league tables and that sort of stuff, is you're compared with everything. You're not compared with who is relevant to you. It's not a peer level comparison, it's you in the context of everything. Might be going full nerd, but Hitchhiker's Guide to the Galaxy, if anyone's read it, there's this thing called the total perspective vortex, and it's you in the comparison of the entire universe. That can feel like what data transparency is. It can make you feel like you are this tiny little dot and you're compared to everything. Is that helpful? Perhaps not. So we believe that if you can get to a peer level comparison, that can help you make decisions. So, a little video, hopefully. But we did some myth busting. So here's what a correlation looks like. This is deprivation data, deprivation index versus house price. This is, you can see there's a correlation. There's a line that goes from top left to bottom right. That's not a correlation. What this is deprivation against quality of care. So we have mapped the deprivation of a certain area against quality of care, A&E performance, quality of food in a hospital trust, all sorts of different things. The upshot of this is ultimately that no matter where you are in the country, you can be in the most affluent area, the most deprived area, the quality of NHS care doesn't change. How cool is that? What a great story for the NHS, that there is no such thing as a postcode lottery when it comes to NHS. You can, if you want to try and find a correlation in that scatter, be my guest. I've tried it. The whole point of this is we're able to then give trusts the right to reply. You can say that, yes, we're in the most deprived area, but the quality of care is not affected by the deprivation in this area. And that's a phenomenally powerful message to take out to the wider public. If the public can see this, and they can, right now, they can find that data if they have the time. It's not presented yet in a way that they can really see it immediately, it's not front and centre, but if you're a journalist trying to write a piece on the NHS, and that in bad areas of the country, NHS is failing, and that if you're in a deprived area, automatically that means that you're getting worse care, you're showing this. Actually, we have empirical data that we are currently tracking, it's open, it's available, why did you not look this up first? That's really important, and it's so powerful to be able to do that sort of thing. So we can myth bust with data. That's a really, really interesting part to this entire platform. The next hypothesis was, we believe that by comparing service information between trusts and between CCGs, we can foster a culture of learning across the NHS. So, in summary, if you can compare, you can learn. If you can find somebody who's been where you are now and solve the problem, you can learn from it. So, the question is, why do we never hear the good news? Why do we constantly hear about the places that are failing? We don't hear enough about the places that are really succeeding and the fact that they're mentoring other trusts to do better. And our belief is because we're not connecting the two, because one doesn't know about the other at any point, because they don't have access to that data to be able to say, I'm in a bit of an issue at the moment, I know what the problem is, but I don't know what the solution is. So I'm trying to pull something out of thin air just to kind of work out how to solve this problem. Wouldn't it be great if I could find someone who'd been there last year, or last month, or last quarter, or yesterday, and they found a way to then improve? Let's go and talk to them. Let's go and learn. So, here's another video, just how we can show you areas to learn one from the other. So this looks quite complicated, there's not really any correlation in there, unless you tick this little box on the left hand side, which maps it, which are acute trusts and which are mental health trusts. There you go. That shows that acute trusts are really good at safe staffing. So safe staffing against financial performance. Safe staffing really relatively pretty strong in acute care, but not so good at financial performance. It's got a huge breadth. Whereas for some reason, I don't know if anyone's noticed, but mental health care trusts never go into deficit. I don't know why that is, but for some reason the data we've got shows that that's the case. Now, if you're an acute trust and you're having problems with financial performance, rather than talking to everybody, go and talk to a mental trust. Talk to mental health and say, how is it that you're able to do this? It's worth a question, at least. It's worth starting the conversation. And likewise, if you're a mental health trust, if you're trying to control safe staffing, because you seem to be struggling, talk to acute trusts. I mean, there's so much that might be under this. There might be some amazingly reasonable explanations for all of this. But isn't it worth starting the conversation on a simple level like this? If you could see it straight away, who are we going to talk to? Let's learn from each other. Let's learn one from the other. Put them together in a room. Start to talk about these things. It's not rocket science, but it's just presenting it in a way that makes sense. So our conclusions from all of this were that the possibilities of My NHS are freaking endless, because you can do so much with all this data. There is so much available, it's so powerful, it's just currently quite difficult to bring together and present into insights. Because although NHS data is hugely powerful, data alone is not enough. Because people don't live and die on data, they live and die on decision. And decisions are made on insight which is built on data. So if we can present that in a way that people start to make better decisions, that's how we can empower them to take responsibility for results. So Jeremy Hunt yesterday said, outcomes are better when patients take ownership and responsibility for their own condition. We've got our own version of that, which is, outcomes are better when we empower you to take ownership and responsibility for your own decisions. Now, if we can help you make better decisions by using the data with something like NHS that already exists, with data that already exists, what an amazing world we can build. And the point is that the data needs to be timely, it needs to be disaggregated, this is all at the rawest level, it needs to be anonymous, so we're not singling out individuals, singling out trusts, yes, but that's useful. Singling out individuals is less useful. It needs to be layered, so we're bringing in new insights, we're adding new perspectives to drive new insights to help people, again, make better decisions. And the impact on this is absolutely phenomenal if we can do it in the right way. So that's what we're doing now. The last bit is all we're talking about the future. So we put together just a rough look into a year, 2 years time, if we continue on this plane. The stuff that Julie and her team are doing is absolutely phenomenal. The fact that it's not been up and running and really live for very long, and see how far we've come. If we can continue that, if we can start to harness the enthusiasm of the wider NHS for this sort of data and for these sort of tools, what can we do? So how can we unlock opportunities for NHS leaders, management, healthcare professionals and patients, the secondary audience of NHS to improve healthcare outcomes? So imagine you're in a trust and you're empowered to make decisions. This is your dashboard. So logged in is Mr. Hunt, but logged in as yourself. And immediately it's presenting you with not everything, it's presenting you with 4 metrics that are important to you. Because it understands that the level that you're at, the decisions that you can make, these are the things that are most important to you. So it's taken all of the weight of that data and presenting it to you in a way that's actionable. Because you can instantly see the big black line is you. How are you doing? Now, it's presented the things that are not going so well first, but it's also presented the things that are going well. So, for example, safe staffing, you are up 8% relative to the rest of your peers. It's compared it in a way that's useful, it's compared it in a way that is comparable, you can trust, and that allows you to make decisions knowing that anything that you do is based on something that's defensible, rather than saying, I make this decision because the data told me this, even though I didn't really trust it. And I now have to live with the consequences. So the idea is presenting all of the things that are important to you in a very, very simple way that is easy to action. So, for example, let's look at A&E, top left, down 13%, which is your performance relative to your peers. What do you do next? So click into that, and it shows you where, in the grand scheme of things, amongst your peers, where do you sit currently? Which group are you part of? And that's your dotted line. You're part of this group, so you're not alone, which is comforting, but you're not doing particularly well. That's something that fine, you can take on, but it's not hammering you for it. It's not saying, you're not doing well now, fix it. How am I supposed to fix it? You're telling me to do more with less, you're telling me that I'm not performing next to everybody else, but you're not giving me any way to actually do anything with it. You're giving me the question, but you're not helping with the answer. That's what this is here to do. So the next one down will show you relative to your peers in a time, using time series data, where have people gone where you've gone and changed the direction. So if you look, I might need a little bit of help, but if you look at the top line, green line, they went through a period a couple of months ago where they started to go all the way down, the same way that you are, and they turned it round. In a very short space of time, they went from this straight back up, and now they're outperforming you. That's not to make it look like they're doing better than you, and that's the end of the conversation. The important thing is where they were before. They were where you were 3 months ago. Maybe let's start from the how do they turn it around? If that's something that I can do something with, that's something that I can really make a decision on. So, how do we get in touch with them? Where are they now? Here's your dotted line. This is where they are at the moment, relative to 4 key metrics that make up A&E performance, and there's the contact details at the bottom. So this is something that we can currently do. This is not a Minority Report 6 years away, kind of blue sky future thinking. This is eminently achievable. So you find someone who has been there, done that, got the t-shirt, and you talk to them about how they turn around their trust. Now, it's not difficult, it's not something that's too far away, but really, that's one story, that's one potential strand of this whole platform. What we want to do is open our kind of our way of working to allow you guys and your peers and everybody else who wants to use My NHS to make better decisions, to compare on a relative footing, to actually help us to refine and design what this thing looks like in the future. Because this is just our view. This might be completely wrong. This might be garbage, for all I know. We're looking at, this could be it. Fine. You come and tell us. So we've got a demo for you to go and play with if you want to. Got my contact details at the end. Come and get involved. Help us out. Help us, Julie, her team, to really shape the future of My NHS, because that's ultimately what we're here for. So with that, Julie, if you want to talk about what's next for the My NHS project, we can talk about the wider implications as well.
Okay, so I'll give you a quick update on where we're at with My NHS. So for those of you who have seen the site, like I said before, it's a single data point at the moment. We've got those 7,000 data points. We want to get to a place over the next probably 12 months it will take us to working with organisations like with Valtech around data visualisation, collection of data, time series data, the ability to create your own shopping basket, which is what Jack's talked to you about. So we selected some metrics that we felt were useful for today around patient safety, around quality, around finance. But there's 7,000 data points and we're adding to that data all the time. It's around you collecting the data that's important to you and creating your own dashboard with that information and using that in a useful sense. And I guess all of you are public sector minded here, so we are going through a proof of concept and the procurement process, so this all takes a little bit of time. So I do think it will be likely to be January before you might see any of this, and then we'll just be building and developing on that over the next 2 years. We have commissioned by Department of Health to take us into this financial year and the next one, and then it's about successfully. So it's already was working. The data going to fund it completely. It's about return on investment. So this will be about users, about communication. It's got endless possibilities. I think everyone can see it can be a really useful site. We've not done any promotion on it yet. We're going to do nothing like that until about January, I think, next year. So it's a word of mouth project at the moment. For those of you who are interested, you can help with our user research and our user testing. So we're always keen to get new people involved. That can be face to face. We do some questionnaires, we do some webinars. So we can know what we can develop it into a health and social care information site all around data, and I think it's just got lots of potential. So that's probably all I would say about it. We may have some questions in a bit around sort of practicalities and where we get our data from. What I haven't said is, Jack alluded to it, we're a secondary publication site, so that data is already in the public domain. It's not given until we do create it. So we collect that from PHE, NHS England, some of it we have ourselves as NHS Digital, but we know it's a bit disparate, so that we're not the data owner, the data providers give that to us, and we're always looking for new sets of data. Part of the transparency piece, what's missing.
And so, outside is that you're the inside track in that programme. We've got your names now as well, so if anyone's complaining in a year about the fact that it doesn't meet your needs, you should have spoken up. So, And the wider implications of this, just before we kind of go into a more open discussion, if we can get this timely, time series data, if we can get this raw stuff and anonymise it, make it publicly available, and actually start to layer it with new data sets that are also publicly available that you might not have necessarily thought was of particular importance to the healthcare system. Also, there's a program currently run about how pain, so people with chronic pain, experience a change in their condition based on the weather. So it's called clouding with a chance of pain. So that sort of thing, people are thinking about this. What other things out there affect the healthcare system that we probably haven't mashed together and tried to understand into? So I guess what we're trying to think of now is how can we continue this momentum whilst Julie's building the next phase and getting funding and all that kind of stuff. We think there's a massive opportunity here to do something like this on a trust level. So not using open data, but how about using hospital data that is there, is being tracked, is being collected, is being made publicly available, and pull that up to a trust level. So if you're running a trust, and if you're making decisions, how about a dashboard that breaks it down by every individual hospital to understand how they're performing relative within your trust? How can you start to target on a micro level where the issues are and where the opportunities are to learn and to improve? Why should we essentially sit back and go, well, Julie's doing it now, so we'll just sit back and let her deliver this in however much time we've got and fund the whole thing. We can help to inform this, we can help to inform the user experience, we can help to inform what data is important, we can help to inform what insights are useful and valuable and help us to deliver better outcomes. And that's by building our own proof of concepts on a trust level. So if that's something that's of interest, we think it could be really valuable, really important to influence and to inform what my NHS turns into by building dashboards on a lower level, not using open data necessarily, but still using the same concept. We've achieved some significant stuff in a couple of weeks. For low investment, if we can do that on a trust level, we can really start to make a difference. So let's make this happen. Let's just keep talking. Everyone get together, put your minds together, and we can achieve massive things. It's already been done, it's already come in, so let's get into the track. Thank you very much for any questions. Got a microphone to around, so you have to shout.
Is there a list of the data sources there? So if the public don't want to cover them, because I'm not going to use we have no data having a go-to place. Anything we can get around instead of having to extract various sources. What's that
Is this on? Can you hear me? Yeah. So we do have, at the moment, you can have a list of, so if you look at our landing page, it will tell you all the data we have that's available, and we have a download page, so you can do a CSV file of any of the data that we have, and then you can start to play with that yourself. Part of what we want to do as part of our proof of concept is open data, 5-star open data. That's what we're aiming for. So you can download and mash them up and play with it as you like. But at the moment, it's a simple CSV.
So, hello, we want to be a little institute because it sits right up my alley. Great. Just to be clear, so all the data that you use on this is open data, publicly available, free, etc.
Yes. Yeah.
And the question on talk about the concerns and constraints in capturing the staff process, interested in more about as well.
So some of those constraints were actually due to the short duration of the discovery phase. So we wanted to make sure that we found projects which had come out with real deliverable and real insight from just 2-week discovery. So it was all about working with the right stakeholders and we're working on the right quality so that we are delivering a real working prototype with real insights from the data. So that's where a lot of those constraints came from.
We also had some some constraints around accessing the data. That's accessing them in a timely way. So, we literally had a meeting with Julian and said, right, so we're going to start on Monday.
This was on the Thursday, yeah.
Right, okay, we're going to run it for 2 weeks, and at the end we'll have some stuff, and just the wheels of government and trying to get access to the data was one of the things. So getting that all out in the open and going, what's eminently achievable? What do we know is already you're not going to get that in time? Things like A&E admission was something we received right at the end. We were able to do something at the end, but we knew that wasn't going to be something we just click our fingers and submit to that instead. So getting access to it in the right format, that sort of stuff. Just understanding those constraints and those concerns. I mean, there's always concerns about open data and how it's going to be produced. There were some concerns about this, about us talking about it, because as with all these things, it's in progress. We want to be sure before we go out and talk publicly about it. Even if the data is available, the insights that you can drive are sometimes a little bit nervy around kind of things that we can talk about. So that's something as well.
So can anyone be user tester?
Yes,
Absolutely.
You want to talk to me afterwards?
Yeah.
We can arrange that.
Anyone, tell your friends. The more people we get hands-on with this, the better. Because ultimately, everyone in the country is going to be a user, whether you're primary or secondary audience. So there is nobody that we're going to say, no, sorry, you can't use this service. Everyone uses it, so everyone should be involved. That's ultimately what we've got to try and do. The call to that, come and help us shape the future.
We've got demo that we can pull out.
Thank you very much. Really appreciate the time. Get in touch if you want to hear more. Thank you.